Join us as we explore the science behind benzodiazepines, from liver metabolism to clinical tolerance. So we're continuing our discussion on benzodiazepines, and we'll talk about kinetics. Now, kinetics is the science of studying what the body does to a drug. So it's about how the body metabolizes the drug. Now, the cytochrome P453A4 enzyme system mediates the oxidative metabolism of many benzodiazepines. So effectively, the liver metabolizes benzodiazepines via the CYP3A4 system. Now, that's not true for all of them. It's important to understand that there are two phases in liver metabolism. First phase is usually phase 1 oxidation, which is a transformative process. And then there's phase 2, which is glucuronidation, which is a further solubilization. So most benzos undergo oxidation reactions, i.e. by CYP3A4, but some benzodiazepines do not undergo oxidation, which is a phase 1 reaction. They bypass phase 1 and they go straight to phase 2. And the benzodiazepines that do not have phase 1 metabolism, I remember them by the phrase transient loss of consciousness, because benzodiazepines cause transient loss of consciousness. And so they are TLOC. Temazepam, lorazepam, oxazepam, and clonazepam do not undergo oxidative phase 1 metabolism, and therefore are less likely to be accumulated in situations where there is liver impairment. So elderly patients and patients with liver disease have a relative reduced capacity for phase 1 metabolism. And so therefore, the half-lives of benzodiazepines that undergo phase 1 metabolism can be prolonged. And so it can take, the metabolism can take 2 to 5 times longer than in patients who are younger or who do not have significant liver disease. So if you're going to give a benzodiazepine to someone who has got liver disease or to someone who is older than 65, you probably need to be considering a benzodiazepine that does not undergo phase 1 reactions, but goes straight to solubilization, i.e. glucuronidation. And so you would choose a TLOC benzodiazepine, temazepam, lorazepam, oxazepam, clonazepam, because these benzodiazepines are less likely to accumulate and therefore are less likely to cause toxicity. Now, I've said that the commonest reaction for phase 1 metabolism is oxidation via CYP3A4. Therefore, if you have a drug that is metabolized by CYP3A4, you are prone to inhibition and inducing that enzyme, and you're prone to the kinetic enzyme interactions that creates. So I'll give you some examples. So a drug that inhibits the function of CYP3A4 will raise the plasma concentration of any benzodiazepine that undergoes oxidation. So antifungals, the use of ketoconazole and itraconazole will increase the concentration of diazepam. Macrolide antibiotics such as erythromycin, antidepressants such as fluoxetine, and antacids such as cimetidine, these will all increase the plasma concentration of diazepam and any other benzodiazepine that undergoes oxidation. And the opposite is true. So inducers of 3A4 will reduce the plasma concentration of benzodiazepines that undergo oxidation. So antibiotics such as rifampicin, antiepileptics such as carbamazepine, phenytoin, and phenobarbital, and glucocorticoids, these will induce CYP3A4. These will make the liver chew through diazepam much more quickly and therefore reduce the plasma concentration. So if you're taking these drugs, you might actually have to increase the dose of diazepam. Diazepam kinetics are clinically relevant, and to summarize, most benzodiazepines undergo an oxidation reaction followed by a glucuronidation reaction. Diazepam specifically has active metabolites. So the oxidation reaction of diazepam will actually cause the production of further bioactive metabolites, including nordiazepam, temazepam, and oxazepam. So I'll say that again in another way. Temazepam and oxazepam are actually metabolites of diazepam. And that's why temazepam and oxazepam do not undergo phase 1 oxidation, because they are themselves the product of phase 1 oxidation. And that's why if you're doing a urine drug screen, you might actually have a range of benzodiazepines in your urine drug screen, having only taken one molecule, one diazepam molecule. We're going back to dynamics now. We're talking about clinical indications. I've said that the half-life of a benzodiazepine really does determine its therapeutic indication. And we know that the half-life of diazepam ranges between 20 to 100 hours roughly, and that's if we include active metabolites. We know that the half-life of chlordiazepoxide is roughly the same as diazepam. Clonazepam is about 54 hours, nitrazepam 48 hours, alprazolam 25 hours, oxazepam 15 hours, temazepam 15 hours, and Stilnox 1.4 to 4.5 hours. And that was the range of half-lives in descending order. So if we were going to use a drug to induce sleep, then we would need to use a drug with a very short half-life, i.e. something like Stilnox. If we were going to use a drug for sleep maintenance, then the half-life would have to be short, but not very short. So enough to put someone to sleep, keep them asleep, but then wear off in the early morning so they could wake up. Anxiety requires a benzodiazepine with a medium to long half-life, and that would include something like nitrazepam or alprazolam, or for that matter, clonazepam. Epilepsy requires a long half-life, and alcohol requires a long half-life, assuming we're not worried about liver disease. And so drugs like diazepam or chlordiazepoxide would be more relevant in that situation. Tolerance depends on the ability of the GABAA receptor to respond to the benzodiazepine. And there are various ways that we can see tolerance emerge. So first of all, we can have uncoupling. So even though the benzodiazepine binds to the GABAA receptor, there is an uncoupling, there is a loss of efficacy. So there is a loss of interaction between the benzodiazepine and the GABA binding site within the GABAA receptor. The next way we can see tolerance is by receptor internalization. So actually the whole GABAA receptor actually gets internalized and buried inside the cell rather than being exposed at the cell surface. So effectively, if you don't have a receptor at the cell surface, no amount of benzodiazepines floating around in the extracellular space is going to have any clinical effect. And then we have specific GABAA receptor insensitivity. Now, I've said before that benzodiazepine sensitive GABAA receptors are actually the subtypes where alpha 1, 2, 3, and 5 are present. In certain situations, the cell will express the alpha 4 subunit within the GABAA receptor. And remember, alpha 4 and also alpha 6 subtypes are benzodiazepine insensitive but neurosteroid sensitive. And so the cell can change the configuration of the alpha subunits in the GABA receptor and therefore render that GABA receptor completely insensitive to benzodiazepines. So here's a description then. We've had uncoupling, internalization, and receptor insensitivity. And these are all ways by which we can see tolerance to benzodiazepines. By that we mean we need to have an escalating dose to achieve the same clinical effect. Now, clinical tolerance can take 3 to 14 days to develop, specifically to the soporific effect, i.e. the ability to send someone to sleep. And it's rare to get rebound insomnia after less than 10 days of use. But once you get to the 10 days, that's really when you're starting to see the need to have higher doses. Tolerance to the anxiolytic effect can take up to 4 months to develop. Now, the Royal College of Psychiatrists in the UK, they state in their clinical guidelines that benzodiazepines should be limited to no more than 1 month and the consequences of long-term usage are liable to outweigh the symptomatic relief of anxiety disorders. So this concept of tolerance is really important to understand how long we can actually use benzodiazepines appropriately and safely before we start to get into the determination of dependence. And dependence is a topic that we're going to talk about in the next episode. That's all from me today. My name is Dr. Fergal Armstrong, and this has been Cracking Addiction.